All right. So thank you everyone for joining today. It's been a minute since we've caught up. We've now completed the Delphi process for this work group. So thank you all so much for your participation. I believe we had universal participation across the board. So it's great that we were able to get great results and feedback from everyone. To go over today's kind of objectives, since the Delphi survey is closed, we'll start by going over the overall results, kind of looking at from the highest level, just a list of what met inclusion, what didn't meet inclusion. And then there are a couple of elements that I would like to discuss specifically. So some elements that had specific comments that I think are worth us discussing, as well as some elements that when it came to selection of a definition, we didn't kind of reach a consensus on which definition to select. So I'll be sharing that data with you all. Eventually, I would like to jump into a couple of the items that did not reach consensus. So we do have a few that were close to reaching consensus, but didn't quite reach it. But I would like to still share that with the team, so that way if there's anyone who feels strongly about why it should be included, they can kind of voice their opinion. From there, we'll go into next steps. We will be eventually sharing this information with the CDE steering committee later this month. They will be reviewing all of the work that we've done with this work group. I did want to publicize now that we are also starting a social determinants of health work group starting in the fall. So thank you, Dr. Huebner, for agreeing to chair that. So if anyone else is interested in joining that work group, please do let me know. We already have quite a few people who are interested. The idea is that this group will look through all of the CDEs that have been recommended from all the work groups that are currently enrolled, and then try and look at any potential gaps specific to social determinants of health. So that being said, let's jump into a kind of an overall look at the results. I just pulled up the results. Can everyone see this PDF?
We can see it.
Great. I don't have the little green box. So starting at the top, just in terms of what kind of overall the results were, we had 33 elements that met inclusion criteria, 1 element that met consensus for exclusion, and then we had 8 data elements that did not reach consensus. So almost 80% or 80% met consensus. As I said, I would like to discuss a few of those that met inclusion and then a few that did not reach consensus. Here is a list of those elements that met inclusion. So on the left-hand side, I just have the data element name, and then on the right-hand side, what the consensus percent was. A reminder that for this process, we had determined that an agreement of 80% was the mark for meeting inclusion criteria. So please take a look at these. There is one kind of note here, and that is after especially speaking with Olga yesterday, when it comes to anything that is reporting ICD. So we have a couple that are ICD specific. The way that they were presented to you was specifically for ICD-10. However, that ICD-10 won't necessarily get put directly into the data element name, because one of our core elements is what ICD version are you using. So that keeps us from, as we move forward and new versions come out, we don't have to recreate a million CDEs. We already have the CDE as just ICD, injury diagnosis. And then the users would be able to select which ICD version they used in another element. So these are those 33. Oh, sorry, we had a couple go on to the next page, insurance status, description of events. And then when it comes to exclusion, the only thing that there was consensus for not including was education participation. I believe this was an indicator data element that was just a yes or no. We did have another education element that met consensus that showed more detail for the amount of education for the participant. And then we have a few elements that did not reach consensus. As we see, we have quite a few that are close to that 80% mark. So I would like to kind of look at those a little bit and get everyone's thoughts on these and see if we can get those across the goal line, or whether we should stick with what the results were from the Delphi survey.
Nick, I have a question for you.
Sure.
Didn't we have a member of this work group comment that in an email that they sent out of the survey itself, that they were concerned that participant city in like rural cases might potentially be re-identifiable?
We did. That's something that I think I've spoken with Olga about that. I think we need to follow up with Matt with the FIPR team on exactly those specifics. However, I wanted to be kind of clear with everyone that when it comes to the selection of these CDEs, this isn't these data elements won't be required for collection in any way. This is just so that if this data is collected in a way, that we have a standardized way that it's being reported. So
Hey,
by
Nick, it's Jennifer.
Yep.
I just want to kind of talk about that for 1 second, because
Sure.
in my mindset, I actually lost sight of that. And so, as somebody that like runs a PI organization where the majority of what we do is, from the usual care records and how data is collected. And when we were talking the other day, it just had to kind of reset my mindset. I'm sure none of you guys have this issue, but I did. But just so in case anybody else, like, this is so if you're creating a case report form or CRF, if you're creating something to do research and you choose to use that data element, you don't have to, but if you choose to, then there's a standardized way across all different, research projects that data element is captured, coded, units, everything else. And so I needed that reminder. And so I don't know if anybody else did, but because I'm always thinking like, oh, I don't want to collect that. Why would I collect that? Why? That's not, you don't have to. This is like something that, so I just wanted to take a minute to say that, since I needed my own remediation in case anybody else did as well. Over.
Any other thoughts on these, like the share? We will get a little bit more in depth into some of them here in a second.
So just another comment on home city and incident city. Zip code already met a threshold for consensus. And if you have someone's zip code, you have their city. So on the one hand, if zip code is included, it's very easy, or it is possible to, on the researcher end, derive someone's city. If city is included as a CDE and the researchers have already collected it, or people contributing data have collected city and they are allowed to contribute it, then it saves work on the other end when someone's reusing the data. So it's kind of a like, if they've collected it, it's nice to have. If they haven't collected it, people reusing the data are going to be able to get that information anyway. It would be nice to have it in some kind of standardized way.
So we can jump into a few of the specifics now, and thank you, Dr. Drummond, for sharing that. I saw that on your comments on the survey itself, and that totally makes sense. We can jump into a few others. By all means, I've just pulled a few that kind of require discussion, but by any means, if there's any that are on the list that you would like to discuss as well, we can definitely jump into those as well. So starting with this element, the reason this element is being discussed is that we had two definitions where the ranking for which definition was preferred, they were tied. So there wasn't a clear, preferred definition. So for this particular element, even the definitions that were provided to the group potentially are different, elements. One is very specific to vehicles, and the other one is a little bit more broad. So the FIPR definition that was found is vehicle specific. The NTDS definition is more broad of protective devices. So this is a case where we could select one if we think that one is sufficient, or there's the potential of creating two separate CDEs, one that's specific to vehicular protective devices, and then one that's just more broad. Keeping in mind that there are, protective devices listed under the permissible values for NTDS that are also related to vehicles. So that's what we need to kind of figure out for this particular data element.
I think you can find all the FITBR ones within the NTDS. So child safety restraint, you have child restraint, you have helmet, airbag, other, and seatbelt. I would go with the national standard NTDS.
I think that's fine. I do remember in our discussions that, there was some potential benefit to going with the FITBR definitions when possible. I don't know if that wants to be reiterated here. The question is, is that level of detail desired enough to want to deviate from the FITBR, which captures the basics of all of that? But I really don't feel super strongly about it either way.
And thank you for bringing that up, Dr. Schulman. When we do have two definitions that are extremely similar, we want to try and default to the FITBR definition because this is a repository that already has data collected in that manner. But in this particular instance, there's quite a difference between the two. So I don't see there being anything wrong with us selecting NTDS in this case. The only other thought I had was we may not, this one has quite a few more permissible values than the FITBR does. We have the potential to update FITBR elements if we want to, let's say, like add a permissible value here or there, but there's quite a difference between these two. But that's something that we could bring up with Olga from the FITBR team here. If there are cases where we feel like they're very, very similar, but we just want to expand on the potential permissible values moving forward.
Hey, Nick, it's Jen Gurney. Is there any thought that like if there's so many of these things that are aligned with FITBR that it will sway the NTDBS or any of the other systems to kind of adopt those same definitions? Is that a long-term goal or intent at all that you know of?
Not that I'm aware. These systems that have been in place, as you said earlier, one is more of the CRF-PI, very specific study related, whereas the other one is more just collecting of the data. I don't think, I mean, ideally long-term, yes, there is that type of consistency kind of across the board, but I don't think that's within the scope of the work that we're currently trying to.
I think that's why Jonathan was, I think that's why Dr. Stallings was asking that, a lot of the stuff that we're doing at JTS2 on the back end of our registry is to get everything into a common data model and data standards. And I mean, everybody's kind of saying the same thing, that without, data standardization, we're talking about different things and combining studies or meta-analysis or something else. It all gets very confusing without the common data standard. And the NTDBS is like, or NTDB is that they have, the more that, and I don't know the answer to that, I guess this would be for Olga, how aligned. I know FITBR has a lot more detail, but pretty much all the definitions are pretty much are otherwise aligned. Is that a true statement?
I wouldn't say that is exactly a true statement. Like in FITBR, we did not cooperate with NTDS. Whenever possible, we looked at the NTDS when we've been developing our data elements, but quite often what we developed was actually data driven. So it depended on what kind of data we've been receiving. So I wouldn't say like that is 100% a true statement, but when we develop our data element definition, we do look in the other data dictionaries, and we try to make our definition, like we try to piggyback on the people who are better than us. Well, let me word it that way. Does it make sense what I'm saying?
Yeah, it does. Thanks, Olga. Dr. Stallings, for you?
I look at it as the FITBR is a trauma database. The NTDS is a national trauma data element standard. And it just makes sense to have any commonality between those data elements to be harmonized. I know FITBR is going to have a lot more data elements that are research specific and things like that. But, pretty much all of my comments or things that I didn't agree with or recommended in the survey was essentially adopt the national standard data element where you can. I think that would be prudent for the small number of data elements that are captured from the national data standard. Over.
You got something to add, Michelle?
I was going to say that this sounds like a situation where what this work group might want to do is in the report that we prepare for you, and you'll see and that, before we take it to the CDE steering committee, we might want to say, like, in this case, there was strong support for including FITBR and NTDS, and for these reasons, because you can't both. You could recommend that we make both available. Again, you don't have to use both. So that's an option.
Thanks, Michelle.
I'm a little confused how you use both, though. I mean, this is it's a variable and it's only going to have one data definition.
Well, I guess I could argue that one variable is vehicular protective device type, and another variable is a more general protective device, and that you could recommend that both of those variables be included in the basic set, but that an individual project probably would choose one or the other. Like if they're trying to align with other studies that have used TQIP data, for example, they would want to use the NTDS, is what I was thinking.
We got Olga, and then Smitty, we can get you next.
So I understand why people from this group possibly want to have two data elements, but in FITBR we are trying to keep the number of our data elements somehow limited. And any suggestion like we should adopt NTDS or we should adopt FITBR or both, I believe they should be discussed with the FITBR program and should be made on the higher level, because that will affect the existing data in FITBR, that will affect how people submit data in the future, that will affect the number of data elements in FITBR. So that is something which I believe needs more detailed discussion. Does it make sense what I'm saying? Thank you.
So for the FITBR data element, is that element not filled in if the accident did occur in a vehicular accident?
That means we didn't get this data. We get data only if the accident occurred in the vehicular type, like that's the vehicle. I don't know how to say it.
Yeah.
That means so far we didn't get any other type of data.
Do you know how often it is filled out?
Not from the top of my head, but I can look up on where it's used and how many data we have.
Smitty, I want to circle back to you.
I think
Most of my point has been taken care of. When I look at these lists, though, there's some key interoperability issues where, child safety restraint doesn't perfectly match into child restraint, maybe, possibly. There's also differentiation between lap and shoulder belts in NTDS. I, I think it's reasonable to include both when we're saying, these are the options. But I think the general consensus that I'm hearing that I agree with is that we should be encouraging a harmonization across both data sources.
So Olga, can this discussion over this particular topic get brought to those that would make that distinction on whether these are differentiated enough to create both or adopt both?
Well, we can bring it offline and we can take a look. Like, honestly, I don't see the reason why we don't have protective devices. But what I will need to do on my side in this particular case, I will need to link these two data elements, and then the data would be findable. So if we decide to do it on the one by one level, that would be workable. But if we decide, the group decides, like, we need to adopt all NTDS data elements into FIDBR, that's a much bigger discussion, and that needs to be brought up with the FIDBR program.
So we'll be running into this, FITBR, NTDS concern for a couple more of these. In this case, it's a very broad injury incident date. In this case, the definitions are essentially the same thing. So to me, in this case, we already have an existing FITBR definition that exists, that is used. There's an NTDS definition, but they extensively are saying the same thing. In this case, we had two that were tied. Thoughts?
In general, I would favor the more specific definition of including the time, especially since there's an option for it not to be included, it seems. I think having that available standard is really important. The more specific any of these definitions could be, the better.
Yeah, let me check for a second here.
Yeah,
Yeah, so
also
yeah,
the time, yeah.
yeah,
I think
so
it's a separate field in NTDS. I remember from the
correct.
survey.
Yeah, two fields in NTDS.
So that's the next two slides. One is date, where FITBR has made it date time, whereas NTDS has made one for date and one for time.
I think that boils down to data structure. It's really a structure question, whether you want those two separate fields or you want a date time field. And it depends on what kind of processing and cleaning infrastructure is available. I don't know that it matters from a Delphi or evidence perspective, as long as the data management team has a plan.
Olga?
Yeah, I agree.
So the injury date time element allowed to capture date if necessary. So the database allowed to capture date without filling out the time. So that means, I believe, FIDBR1 simply fits both. If you have only date, you can fill it out using this element. And if you have more precise measurements, you can fill out date and time.
I would favor kicking this particular decision to the data management team, because if we can get it either way, I think it's what makes sense for their infrastructure.
Yeah, I think this is an example. If you don't harmonize with the NTDS, you are essentially still collecting the same data. So it's not that big of a deal. There are some, yeah, it's all on the data management side. on whether you want to clean a field that has partial data and things like that. So I think that's why they keep them separate in NTDS.
Are there other fields that request time of admission, other times?
I'd have to
Yes, for
pull-
admission and discharge. Yes.
Yeah, so entry time is only useful if there are other times to to do analysis with.
So as you said,
Hey,
Dr. Stone.
Dr.
Good.
Holcomb, great point. I mean, the time to capability in terms of clinical outcomes. So if we only are capturing injured time and we're not capturing other time, but that might be in some other work groups. So I think that's something that we have to bring to the other work groups because it's more of the care capabilities. So time to intervention, whether it's transfusion to the OR to airway, whatever it is. So I think that's a good point. Over.
There also have been studies in the past looking at the particular time of day an injury occurs, more likely in the morning or in the evening, and how that affects things. So it's not just in relation to other variables necessarily.
In my experience, it is the least accurate variable in a registry is the injury time. Over.
Yeah. And I would say, in my experience, part of that lack of accuracy is based on how it's collected. So again, I would agree with we need a standard, but it's probably better to defer to the data scientists for the entire registry or the entire repository to pick the one that they believe is the most manageable. Like most of the problems I've run into are using 24-hour time versus 12-hour clock and AM PM, or times around midnight, and just having a standard would be very helpful.
I agree having a standard, but you still have to have the EMS run sheets. And so is it injury time? Is it call time? Is it urban injury time? Is it rural injury time, et cetera, et cetera, et cetera. It's much beyond just the methodology of declaring 12 or 24 hours around midnight.
Gonna go for it, Olga?
And I would like to suggest that for this round, we keep the number of data elements we consider very small, because so from my expertise as a curator and data curator and FIDBER, it's much better to have a smaller set of data elements and then add data elements when you start submitting your data, and then revisit and consider which of those additional elements could be considered the core, than to try to decide of a big list of data elements before we actually try the data submission. Does it make sense what I'm saying?
But we're not talking about core data elements here. We're just talking about common data elements. These won't be required. These will just be standardized. And if the study chooses to collect them, they'll have to be collected in this fashion. So that means studies moving forward, if they use these data elements, will have to collect it in this fashion. These are just basic data elements that I thank you for the wording, Michelle. These are just basic data elements that we're trying to standardize, but these are not core data elements, which we definitely want to minimize.
The next data element for discussion is related to occupational industry, so the patient's occupational industry. A specific reviewer comment for the top definition, these are both FIDBER definitions. Over your comment for the top one, is that this is a NINS CDE. Here's the specific ID for it, and it's going to have the most comprehensive list of permissible values. So if y'all want to take a second to look at these and let me know your thoughts. So once again, these had a tied preference in terms of use and adoption for these two definitions. Is there anyone who'd like to claim a specific definition as to why it should be used?
I'd go with the simpler variable.
The simpler is in the fewer permissible values.
Yes, I would say the same thing. This is Jennifer, I'd say the same thing. I was just about to say that, and Jonathan beat me to it.
Strongly agree.
Almost all the variables where we have tons of options, we eventually simplify them for analysis purposes.
I agree. The only caveat I would add is we should make sure that the types are mappable into the categories. So the first variable is mappable into the second, which looking at them, it kind of looks like it's a cascading question. Like you start with the first, answer the first question and give more detail if available. Is that right?
I don't believe so, but Olga, I don't know how familiar you are with this element. I don't believe it's logic like that.
It is not logic like that, and unfortunately, the occupational industry, it's a tricky data, and I would again, if it is convenient to the group, we are in FIDWR, we are trying to adhere with NIDS CDs whenever it's possible and convenient. So, and harmonizing like from the very comprehensive list to the less comprehensive list is actually easier than vice versa. So maybe having the more comprehensive list would be more useful for the group, but that's my suggestion.
So we've got a few for either. Do we want to try and let's see how many people do we have on the call currently? As we know, this was tied before.
So can I ask a question, Nick? This is John Holcomb. I'm sorry for being late. I've never written a paper or I've used any of these categories. And maybe that's my lack of knowledge. But
these are elements that just happen to show up frequently in the papers and data sources that were recommended by the work group. So there for sure may be some that you or others may not have be familiar with. They just happen to be the ones that were commonly collected in the sources that we looked at.
Yeah, Dr. Holcomb, this was, I mean, these aren't random. These are, we all sent
No,
papers
yeah, I
in
know.
and they, but I agree. I mean, I have personally not done a paper with any of these either, but they're certainly these data elements are in the literature.
So in the trauma patients that I took care of 2 weeks ago, I couldn't begin, I mean, none of these, and maybe they should, but none of these categories were anywhere in the history of the present illness.
But this is something that if you were designing a research study and your case report form had it in there, it would be probably coded by an administrator or coded by the ER admin, or not coded, documented, and then you go back in and get it. We started the call with, those comments that this is not stuff that are necessarily usually collected by physicians or nurses, but these would be things that standardizing data elements when people go back and do, outcomes research or whatever from the record. So, but yes, agree. We don't write this stuff down, but it gets collected by somebody. Over.
And in the case report forms that I've done in the last year, none of these categories are on the case report forms. Over.
Well, I'll let somebody else take that one because these were in the papers that we sent to Nick and the team to pull. So, these are data elements that you might not, look at in the research you do, but in the epidemiology, trauma or whatever, these are in the literature. Were not made up. These are data elements that are used in trauma research papers. Over.
Yeah, so acknowledging all of that, I'll just comment that the top expansive group is pretty complicated, actually. I mean, it breaks down professionals by longer tertiary education versus typically a bachelor degree or I think it's actually going to be a lot of, first of all, the level of data fidelity for getting this from a patient in a history, like Dr. Holcomb says, is going to be extremely rare. And I think it's kind of confusing, to be honest with you. So I'm still in favor of the simpler version. I think there's plenty of detail there, and realizing
Agree. Yeah, totally agree. I think that keeping it already is a to me like a detail that I'm not sure why anybody would necessarily want to do research on it, but people obviously do, or we wouldn't have pulled them. But keeping the definition as simple as possible once we've decided that this is a data element, keeping it as simple as possible. Totally agree. So Nick, how close are we on this one that you're showing it? Was it 50-50 or?
It was 50-50, and it sounds like from the call currently, I believe it's 4-2.
Yeah, so it sounds, yeah. I mean, one of the things on the call today is for these that are close, we do need to adjudicate them and come up with a, so has everybody kind of weighed in? The top definition that has all the information, bottom different definition that is a fair bit simpler. Everyone should weigh in so we can adjudicate this and move on to the next one. Over.
So if you're in Texas, you need to have oil field worker on here. Is that a laborer? I don't know what a craft worker is. I do know what a social worker is. But I mean, social worker is like one person, right? I don't know.
So, Dr. Hogan, what are you saying? You're saying you don't like any of the definitions, or you prefer the bottom or top? Which? I've
not gone through FITBR, which is the data source, data definition source. I mean, I've written a couple papers and I've read a lot more. I can't think of a single paper that I've read in the last 40 years that has these categories in them.
I think in the literature, these categories come out more in like epidemiology and injury prevention work and not so much the clinical outcomes. So it would be if we can identify an occupation where a certain type of injury is especially prevalent, then we can target an intervention to prevent it in that occupation.
Well, I read the epi literature. I agree with that. And fishermen, like commercial fishermen, is one of the most dangerous that there is, and it's not on there. And oil workers
and fracking, fracking.
Second.
We see that a lot here in Texas. Yep.
Yeah, and the guys who work rodeo, the rodeo guys are third to those three categories. Now that's
I will say,
but none of them are on here.
Just to jet in here for a second. So there was another data element that's specifically the occupation itself. So let me pull up that data for that. There were two data elements. Occupation met consensus, and there was agreement on the definition. The occupational industry did not. There's, they're very similar, but let me pull up that data for that, and that may add some value here to to our selection process. This is in the Excel sheet that I sent out. I didn't want to get too deep into this because, as you can imagine how long it's taken to go through these handful. We can't go through every single element. This is the list. So it looks like, let me see, is that actually this one? No, okay. Let me pull this back up. Here is the element that met consensus for a very specific definition. So both of these met consensus, both occupation as well as occupational industry. This definition had a preferred selection, whereas industry did not. So here's a list here in this particular grouping here on the right-hand side for occupation. So that we're looking at a lot more detail here with occupation, whereas the industry, maybe we could go to a smaller list of permissible values since there's so much detail in this other element.
It's funny, when I look at this now, I probably voted no for occupational injury on the first go around, and maybe one of the subsequent rounds, I let occupational industry go through, not realizing we had already let occupation go, because now I'm wondering the merits of it. I don't know that you need industry when you've got the actual occupation, but I don't know that we can go back from here. Because remember, when you went back for the Delphi, I didn't show you the ones that reached consensus, so I probably forgot that we had done occupation. Maybe others did too, I don't know.
I can pull up all the definitions for both if you would like to circle back and maybe select one between all of these options. That's something we can do if you think that might be useful to the discussion.
Yeah, I think that would be, I think from a end user standpoint, we need some measure of occupation because that is an important variable in injury. But there probably only needs to be one standardized common data element for occupation. And we have a lot of different ones we can choose from.
So here's all the data that got put into the survey. I don't have the survey available for display. And that was just small. I'll try and make it as big as I can while we can actually still see it. Let me make this full screen. So here's patient occupation. We had 3 options for selection. This middle option is what was selected. I believe Dr. Stallings has also added the NTDS.
But the patient
version.
occupation variable made it through.
Yes. Both of these variables made it through. It was just one had a preferred definition. So for patient's occupation, there was an actually preferred definition that came out on top. Whereas when it came to industry, there wasn't.
Oh.
So we, as you brought up, if we want to potentially look at all, 3 definitions here and 3 definitions here, and then go with one that we feel like deals with occupation, we can definitely do that as well.
The
But now we're talking
NTD
about 6.
Yeah,
Go ahead, Dr. Stallings.
I'm probably was in the minority selecting NTDS over FITBR all the time, but yeah, they're very similar. The job classification ones, it kind of covers what the bases with those other variables, to be honest. And these are actually more comprehensive and informative because they both have military occupations in addition to others. So yeah, either one is good. I just prefer harmonization with NTDS, NTDB.
Am I allowed to make the motion that we just leave it at patient's occupation?
I think that's a good idea. I second it.
Heard it.
Okay, so the go with patient's occupation. And we will not deal with the industry itself. And then do we want to now relook at the definitions for industry or sorry, for just occupation?
I would
Dr.
keep your
Stallings?
results. I would keep your
Okay.
results from the survey,
Okay,
because I think I had a lot of bias with NTDS throughout I'm probably the dissenting 14% on a lot of this. So
any other thoughts on this before we move on? I appreciate all the dialogue. Okay. Next topic for discussion is insurance status, method of payment, a couple of comments. Right here. First, will this be multi-select? If not, we may need to specify primary insurance. And then another comment, technically the CDE captures not the insurance type, but the patient's method of payment. So, and this is another example of the two different definitions, one NTDS, one NINS, where they're asking slightly a different question. This is I think, potential of, do we want to go with one, the other, both? If we do go with one, do we want to make sure it's a multi-select? We have a couple of different kind of things going on.
We're gonna be here forever. So I think, you know,
Only
the
got only a few
NINDS
more.
one- The NINDS one is a little bit more comprehensive. It includes veterans of military. I like it a little bit more, and I'm not sure you want multi-select. I mean, it should be the primary, because everybody's self-pay when their insurance falls out. So, I don't know that it needs to be a multi-select. So, NINDS looks pretty good.
I second that.
Yeah, I agree. I think NINDS for me, one of the primary advantages is it has the employee sponsored, just like it has what it isn't labeled as workers' comp, but essentially a workers' comp, which again seems pretty important for injury.
Okay. Great. Dr. Stallings, I believe you commented on this regarding TQIP permissible values. So when we pull definitions for this particular element, trauma type, just being very broad categories, blunt, penetrating, thermal, things of that nature. The only thing that exists within FIPR is what's called a unique data element. And what that means is that it hasn't been adopted as a common data element, a CDE. A unique data element is something that a researcher created for their particular study, but hasn't been widely adopted as a standard. So I wasn't able to find from my end these TQIP permissible values or a data definition for this particular variable. So Dr. Stallings, if you have access to that or could provide that, that would be great, because I believe since those already exist and are part of NTDB, that it would be much preferred to adopt that than a unique data element that hasn't been vetted and adopted officially anywhere.
So I understand you correctly. Injury type from the NTDBS is already a data element
And
that we've accepted. Yeah, so this would be probably, we don't need this data element then, if injury type is already being collected.
this was just I guess, broader look at the type, like trauma type as a very broad categories versus getting very specific, which we do have other elements that are looking at those very specifics. But when I was looking at the data dictionary for NTDB, did not see this particular element in there. So I don't know where that data is or that definition for it, where, like, for example, these permissible values came from. But if you could share that, then I think it would be worth creating this element from scratch.
But I need that clarification from what Jonathan said. There, we have a separate variable called injury type that includes blunt and penetrating. And now this is a separate trauma type variable. That's what he was suggesting. Is that correct?
I'll look into that and see if I can get it to you.
Are you guys making a difference between trauma type and injury type? I'm a little confused.
Yeah, that's what I'm confused about.
And what, I think that's what I was trying to refer to. If we have the variable injury type already, then trauma type is not
Yeah,
needed.
do we have in this, CDE set, an injury type variable already?
We do not have a CDE that's been approved that is looking at whether we call it injury type, trauma type in this way of specifically blunt, penetrating, burn. No, we do not have that.
Okay, so this will be the only variable that's either injury type or trauma type.
And we can call it whatever we want to call it.
Okay.
Because
Then it should include the expanded categories, that whatever comes out of NTDS or TQIP.
So yeah, Dr. Stallings, I guess the TQIP data element injury type is what we're referring to. That whatever variable title data definition, you've provided the permissible values for it. But if this is an element that we're going to be creating from scratch, which we have the ability to do, then we are going to want to align exactly with how TQIP has defined everything. Does that make sense?
Yeah, I will look up. Is that exactly what I copied into there?
Yeah, I just pulled from the comments.
The comment,
yeah. And we can do this,
I'll get the source and send it to you.
Okay, great.
What you look at, yeah.
Great. Something similar with pre-existing conditions. From what I've looked at the data dictionary, the way that pre-existing conditions is collected, when I'm looking at the data dictionary, is that each pre-existing condition is a separate question with a yes or a no. We know that we don't want to do that when we're creating this repository, because we don't want to be creating many different elements for yes nos. So again, Dr. Stallings, this is something that I wasn't able to find when I was looking at the data dictionary, but you provided this list of permissible values, which I'm sure is coming from the same exact source that you'd be pulling, injury type from. But I can't find where this, variable name, data definition, permissible values, I can't find where that's coming from.
Yeah, I grabbed that actually from the data set. I'll share with you where I got that from the TQIP data set. I just did a study on liver lacerations and compared it, and they have their data dictionary in the data set that's provided, and these are the variables that are provided in the actual data pool. But let me get the actual data dictionary and just verify. Essentially, those are the same variables that are in TDBS, though, I believe, under the pre-existing conditions chapter or portion.
I didn't check all of them, but yeah, they look very similar.
For the TQIP, do you have the TQIP data dictionary?
I have it in an Excel file.
I mean, does Nick have it?
This is the version that I'm using. So I've cross-referenced, what was provided as those permissible values with these pre-existing conditions here.
Right.
off the top of my head, couldn't tell you, do they match perfectly or is there any missing? But the way that they're reported in here is they're each their own element. And if you go to an element, then that element has a description for that element and the element's values are yes and no. So we don't want to be creating CDEs like this at this point in time. It makes sense to make it one element and then have all of those different options be permissible values for it.
Yeah, I'll get the information and send it to you.
Great. And once again, these are all things that reach consensus for inclusion. Now it's just a matter of the finer details of the definition and how the question can be answered. So those were the elements that met consensus that needed some type of immediate follow-up. As you all saw, there's 33 different CDEs that met inclusion criteria. We went through the ones that needed absolute discussion for one reason or another. We have a couple minutes left. Really, it comes down to, are there any that did not reach consensus that anyone feels strongly that these should be created? I've just pulled the top 3 here. So once again, our consensus percent mark was 80%. These all reached 75. So very close, pretty much 1% shy. We did talk earlier about city versus, hey, zip code has already been approved as for inclusion. So do we really need to be focusing on the city at this moment in time? Or do we just say, hey, we've got zip code, we're good for now, and we can let that use that if someone is interested in determining what the city is. And then the only other thing was medical history, conditions, SNOMED, CT code, which I believe Smitty has experience using. This particular element, I believe there was also discussion of, could we potentially add this code, as an attribute potentially to existing CDEs that are getting created.
Yeah, I've got experience using that. I would strongly recommend using existing vocabulary. So instead of, like in that last one we were just looking at, instead of a list of conditions, because it's not always clear how you map into those. If we capture the actual SNOMED and ICD codes that are there, that gives a lot richer and more precise data. Otherwise, we need a really clear definition of each one. When we say chronic lung disease, does that mean just COPD, bronchitis? Does it include asthma? Like there's a lot of nuance potential, and there's a lot of different ways that those get interpreted. If it's possible to just include SNOMED or ICD codes, then we save ourselves from having to write definitions for each one of those possible responses. And then we just track which version they're using of the vocabulary and let someone else manage the updates.
Does that context help anyone who maybe didn't select this for inclusion? So I know some of you just weren't familiar with the element itself. There were some comments on that.
I think I was one of the 75%, so I'm not sure I'm helpful.
There also are, the other thing I'll add is there are some really interesting ways that this can be lived out. There's some ontologies that can be mapped into like REDCap, for example, where there's a type ahead process and you get some auto validation. So instead of going through the checklist, someone could be typing out. I've even seen some interfaces where you can type out diabetes without complication and it'll pull up the ICD code for you. That way there's that kind of iterative validation instead of someone having to go through a checkbox. They can more rapidly enter all the diagnoses that are relevant. But it also depends on what's the minimum viable product for this product.
I will say that SNOMED and MVP are never been in the same sentence, ever.
Glad I can provide you with a new experience.
Yeah, I've worked with SNOMED, and it's not the nomenclature that clinicians use.
No, it's not.
So it depends on the intent.
Mm-hmm.
Right. And so I really think that the intent is, and I'm not I'm not sure I can articulate the intent of this exercise. But SNOMED is not a clinical intent, over.
Right. And for a manual entry process, SNOMED isn't the one we could include ICD, because that's something clinicians are more familiar with. I think that's better. SNOMED would particularly be helpful if there's an automated EHR extraction project. That's when someone would really leverage SNOMED.
And we do have ICD as part of our core as
Mhm.
well. So
Yeah, I would.
Yeah.
Okay.
And ICD gets, I mean, EHRs are all about billing codes. That's why they're there, actually. So it's easy to pull those out.
I want to be respectful of everybody's time. We have used up our time for today, time well spent. Kind of the next steps of the projects. We'll be doing some follow-up, both with sending some elements to the FITBR team with Olga to look at development of potentially having more than one for things like the vehicular protective devices. I will also be following with Dr. Stallings on getting that TQIP data. And once we kind of pull all of that together, then I will share a final CDE selection with the group that will include every definition and permissible value for all of the elements that met inclusion criteria. So that you all can look at that. And then that information will also be shared at the CDE steering committee in a couple of weeks for them to review it, give their feedback, of course, and they may have thoughts and send it kind of back down to the group for further discussion. So that takes us to kind of our next meeting. We haven't put it hard on the calendar yet. We wanted to check with Dr. Gurney and make sure that this time at least worked for the majority of people. This is the first Tuesday. We were originally gonna do the last week of the month, but that is MHSRS. So a lot of participants won't be able to come to that meeting. So we pushed it 1 week past that. So September 3rd, which is a Tuesday at 1300, if that works. Or would you all prefer I send out another doodle for a couple of options?
I think you should do a doodle because so many people aren't here.
Okay.
Yeah, that's a good point. And then Nick, I just wanted to thank you and the team for, putting this all together. It's obviously a lot of work. These aren't really the sexy data elements, that's for sure, but they're important. So thanks everyone for, your commitment to this effort and the time. And certainly Nick, thank you. And yeah, I guess a doodle is a good idea so we can be sure to capture as many people as possible. Over.
Sounds great. Thank y'all so much. Really appreciate your time. If you can think of anyone else who would be interested in doing this process again, specific for social determinants of health, please reach out to me. Thank y'all so much.
Thanks. Have a great day.